My name is Marie-Paul de Valdivia. Welcome to you all here, and for those of you who are streaming and watching us from your home. I am a parent, and I am a DBT clinician, and I have been a volunteer at this conference for about 15 years now. And it is actually 17 years ago today, or conference day, that I came to this conference for the first time. I had picked up my daughter in a residential treatment center, and I was driving her home, and her support team had told us about this conference and said, you might want to stop there and sort of check it out. And so we decided to do that. We stopped here, and it is sort of an understatement, believe me, I'm weighing my words, it's an understatement to say that this just completely changed our lives. My life, my family's life, my daughter's life. This is where I met two founders, the two founders of this conference, Dr. Seth Axelrod and Dr. Perry Hoffman. May their memories be for many blessings. And this is also where I met, for the first time, the person you are going to hear from just now. All of these people just blew my mind. They all spoke, and they made this disorder make sense. And those of you who are family members here, you know how complicated it can be. It's sort of, we look at this and it's confusing. It's hard to comprehend. And as I was listening to Dr. Axelrod and Dr. Hoffman and Dr. Rizvi, I was just blown away. By layers, everything was making more and more sense. So it is such a great honor to be introducing the person who is going to be speaking right now. Generous, creative, brilliant are just a few of the words that come to my mind when I think of Dr. Rizvi, who is truly one of the stars in our DBT universe. She is actually a former student of Dr. Marshall Linehan, the person who founded Dialectical Behavior Therapy. And she is a distinguished licensed clinical psychologist, researcher, and educator. Dr. Rizvi is professor of clinical psychology at Rutgers University, and she is the founding director of the DBT clinic at the Rutgers Graduate School of Applied and Professional Psychology. She is board certified in both dialectical behavior therapy, and you all know what that means because you were listening to what Dr. Decker said about being certified, right? And she is also certified in cognitive behavioral therapy. Her research and her interest and her passion focuses on developing innovative interventions and improving outcomes for individuals who struggle and suffer so much from the symptoms of emotional and behavioral difficulties, as well as trauma. Through her scholarship, teaching, clinical work, and really her deep compassion, Dr. Rizvi has significantly made a difference in our field. It is my true honor to officially and finally thank her for that illuminating talk 17 years ago, and to welcome her to speak with us today.
Thank you. That was, wow, such an amazing introduction. 2 minutes before your amazing introduction, my son accused me of cheating on Wordle today, so life is nothing but contrasts. And I will have to point out to him that at the same time I was being called brilliant. I did not cheat at Wordle today, though I did happen to get it in 2, and that always raises everybody's, yes, thank you. Which is the bigger achievement today? I don't know, but thank you. Thank you, honestly. I was going to start by saying, what fond memories I have of NEABPD. And in preparation for this talk, actually going through my emails and my history I knew I had spoken before here, but not remembered the dates. And so doing that, realized, oh, that was 2008, 17 years ago, that I first talked here, and the day was on trauma, if I remember correctly, that was the theme. And Seth and Perry asked me to present alongside Judy Herman, who is maybe the most well-known trauma theorists and clinicians, and I was so intimidated to stand up there, but also felt like this was part of Perry and Seth's generosity of giving the stage to people that they thought would benefit the audience. And so it was really a thrilling experience to do that. Then they invited me back 3 years later, 2011, to be part of I can't remember what the theme was that day, but it was going to be a panel where people would demonstrate different therapies. And I was being asked to be one of the demonstrators of DBT. And I loved NEABPD so much, and I loved Perry and Seth so much that I said yes, leaving out the fact that I was due to deliver my son 3 days after the conference. And maybe a month or two before I realized not the best idea for me to drive to New Haven to be part of this conference. So I backed out of that. They were very understanding. That son is now 14 and accusing me of cheating on Wordle. So it all comes back around. So thank you to Suzanne and Sadia for setting the stage for this talk. I'm going to try not to reiterate too much of what they already spoke about, but I do think it's important to give a little bit of the background that will inspire the work that I talk about. I also wanted to highlight, I forgot to update my bio. I had been at Rutgers for 15 years. Many of my former students are here today. I am now at Montefiore Einstein in the Bronx, where I direct psychology training and also have been charged with building and strengthening DBT services across the entire hospital system, which is very exciting. If you know anything about this hospital or where it's situated in the Bronx, you know that this is a very underserved population. And so if we can overcome some of the barriers that I'm going to be talking about in that system, we can actually reach a lot of people who would not otherwise be able to receive DBT. So what I'm going to do today, I'm going to give the briefest of overviews of DBT. Now, I know based on the prior talks and based on everybody who's in this room, many of you have been through DBT, you have family members in DBT, you have studied DBT. I ask that you keep an open mind to what I am going to be highlighting because it will both set the stage for what I'm going to be talking about later, but it might be things that are often overlooked about the treatment. So I want to highlight some of those. I'm going to describe what some of the barriers are for people to access DBT, talk about some of the research that I've done addressing these barriers, and end with current and future directions. So that's the stage I'm setting for the next 45 minutes. All right, brief overview. There she is. I have been the recipient of that eyeglass slide more times than I can count. That's Marcia Linehan, the one and only, developed DBT. Actually, as a side note, because I've been meaning to post this to the DBT listserv and haven't yet, Marcia, just on Wednesday night, I was in New York City at the American Foundation for Suicide Prevention Research Award dinner, where Marcia was given the Lifetime Achievement Award by that organization. And Kate Comtois, who also worked for Marcia much of her career, worked with Marcia much of her career, got the annual research award. So it was a very nice tribute to both of them that night. As you all know, Marcia initially developed DBT for individuals, and let's face it, at that time, it was for women with adult women who met criteria for borderline personality disorder. What was novel at the time, because that manual came out in 1993, she started developing it in the 70s. So throughout the 70s and 80s, when she was developing it, initially testing it with women who met criteria for borderline personality disorder, and then writing the manual, it was pretty novel to talk about treating chronically suicidal people in an outpatient form. These were the days of people being hospitalized for months, if not years, at places like Cornell, Westchester, McLean Hospital, and many others. Nowadays, there are residential programs, yes, but inpatient hospitalization is, average length 1 or 2 weeks. So the idea that, first of all, that she was saying these people who have these problems can be treated outpatient was very novel. And that's important because there's a bias, there's a preference in DBT to keep people out of the hospital so that they can learn how to live, right, in the lives that they have. I did an internship at a VA system years and years ago, and I had a client who would routinely every year check himself into an inpatient unit, and he would say, I just need a vacation from life. And I would say, have you considered Hawaii? I hear that's a lot nicer place for a vacation. Because we want people to learn how to be skillful and handle the problems in their lives rather than remove them from that environment in an inpatient unit. We want to keep them at home when possible. It was also designed to be comprehensive. Suzanne reviewed the different pieces of DBT, and what we mean by comprehensive is that when somebody's in DBT, that's the treatment that they're getting. They may also be getting ancillary medication management from a psychiatrist, but DBT is it, meaning they don't also need 12 other therapies at the same time. There are some reasons for that, because I think sometimes we think, oh, well, the more therapy, the better, especially if you have access and can afford it, which of course is not true of most people. We might argue that actually that's not true, that more therapy, especially different from DBT, might get in the way, might interfere because they might have different messages, right? DBT might tell you to do one thing and another therapy might tell you to do another, and that really puts a lot of burden and onus on the person in treatment to figure that out, and that's unfair to them. So we say that DBT, when you're in DBT and you're in comprehensive DBT, that's the psychological treatment that you're receiving. It was also originally tested as a 1-year treatment. Why? Because if you got grant funding from the NIH, a 1-year treatment was the most you could do within the confines of a 5-year funding period and trying to recruit people, et cetera. This is sometimes a misunderstanding because Marcia has never said or thought that people only need 1 year of treatment. And so sometimes people need more. Sometimes people need less. And we don't know enough about that, which I'll tell you about later. And then finally, and this is a final overview point, I should say, in the theme of this conference, is that Marcia described the ultimate goal of DBT treatment is to build a life worth living. And very explicitly says DBT is not a suicide prevention program. And those might sound like they're the same thing, but they are not the same thing. We can do all sorts of things to try to prevent someone from taking their own life. We can lock them up. We can remove every method available to them. We could stand guard over them 24/7. But that is not helping them build a life worth living where they no longer want to kill themselves, okay? So the focus is on building a life worth living. It's interesting because the 1993 manual does not use that phrase, at least as far as I could tell. I recently went back to look at it, but by the time I was there in 1998, that was the phrase that was being used. I don't know. One of the things, maybe I'll ask ChatGPT, when was this first used by Marshall Hanahan, so that we could have a citation for that going forward. ChatGPT is my new friend. Not for Wordle. I didn't use it for Wordle. Okay. Dialectical behavior therapy is a dialectical balance between the change strategies of cognitive behavior therapy and the acceptance strategies of validation and mindfulness. For those of you who are not familiar, that might seem like a bunch of gobbledygook, and I can appreciate that. Again, when Marcia was developing this treatment, cognitive behavioral therapy was becoming more well-known. Cognitive behavioral therapy is primarily focused on helping people change their thoughts and behaviors, right? When she tried to use what we might call standard CBT with folks who met criteria for borderline personality disorder and were chronically suicidal, they would, as she reports, say, "You're telling me to change. You don't understand how hard this is. You don't understand the unique aspects of my life, my history, my family, my biology, and therefore you don't understand that it's impossible to change or it's too hard to change." And that was happening to her so much that she wasn't making progress with what she knew to be the gold standard of treatment, CBT. So she went back and said, I need to revise this, and I need to add in acceptance. I need to add in validation and say, you are perfect as you are. You could not be any other way, given the millions of things that have led up to this one moment, right? And your family cannot be any other way. The environment and the world cannot be any other way. You might notice within yourself a bit of a reaction shows up, even hearing those words. That's what we're talking about, though, as being a form of complete and total acceptance. And we can strive to change the next moment, right? So the acceptance piece is validation, it's mindfulness skills, and then the dialectical piece is highlighting the fact that these are constantly in tension with each other, and to look for a synthesis within any situation and within any person. How do we synthesize the tension between change and acceptance? This is just another way of talking about those three things. Okay. Suzanne already covered the first part here, that comprehensive DBT is these components, individual therapy, skills training, phone coaching, therapist consultation team. So phone coaching, again, thinking about the 1970s, 1980s, when Marcia was developing this treatment, meant something very different than it means today. So I usually say outside of session coaching. Now, when I talk about this, it's really some way to access your therapist when you need help in the moment, okay? The reason for that being, individual therapy, if you're lucky to get a full 60 minutes, is 1 hour a week. There are 267 other hours in the week. When are your problems more likely to show up? Not in that therapy session, right? So, I mean, sometimes yes, but more likely to show up outside. And so what do you do then? Well, you need, what we want is for people in those moments to be able to access help so that they get the skills coaching that they need for the situation that they're currently in. And the theory is that only by getting the help in those moments can you start to build, strengthen, and generalize your skills to your real life. The principles of DBT, I'm going to mention briefly here, but then go into each of them. Well, the dialectical balance of change and acceptance I've already mentioned. There are also key assumptions that inform the delivery of DBT. There's a target hierarchy that tells the therapist and the client what to work on in any given session. And then it follows the principle of a skills deficit model. What I mean by that is we assume that the problems clients have in living is a result of not knowing what to do differently, right? So that is what we would say is a skills deficit model. And therefore, we're going to teach you what you don't know and help you learn to respond to your situation, your world, your environment in a more effective way. That's okay. I was like, what is the secret? Okay. So here are, there's actually more assumptions than the ones I'm going to talk about here. And I don't know how new these are to you all, but I'm just going to briefly go through them or remind you of them. So we ask our therapists, our DBT therapists, to embrace these assumptions when they deliver DBT. Clients are doing the best they can. Clients want to improve. Clients must learn new behaviors in all relevant contexts. Clients cannot fail in DBT. Clients need to do better, try harder, and/or be more motivated to change. Clients may not have caused all of their own problems, but they have to solve them anyway. And the lives of suicidal borderline personality disorder individuals are unbearable as they are currently being lived. The reason BPD is in parentheses there is because the initial assumptions were written for people with borderline personality disorder. Now, as we see DBT being used with more populations, people may or may not include that this last assumption or include the BPD. So what stands out to you about this? I hope one of the things that stands out to you is the non-judgmental approach and the compassionate approach that DBT takes towards individuals who struggle with borderline personality disorder. And I feel like I'm saying this a lot, but just to provide the context that this was groundbreaking when Marcia first talked about this. I think the field has come a really long way, and we have so much further to go in terms of how we talk about people who have mental health problems. And I think Marcia was at the forefront of this. For any of you clinicians who have been in the room with people who don't subscribe to the DBT model, when patients are being discussed, you know the difference, right? And I have always thought to myself, if I knew that people were talking about me this way, there is no way I would seek out their care, right? But that's not a transparent thing. So most people don't realize that. But in DBT, if you're in comprehensive DBT, where the therapist is going to the team, you are embracing the fact or hoping that you know that the clinicians are actually trying to adopt a non-judgmental stance towards you and the problems you experience. I hope you also notice that there's a little bit of a dialectical tension here, right? Doing the best you can, wanting to improve, and needing to do better and try harder. And the tension there is to get out of this stuckness, right? I'm doing the best I can, I want to improve, and I am currently miserable, right? So that means that something has to change. Let's figure out how we can change that. Clients cannot fail in DBT is a big one, and the assumptions I'm not showing you are counter to this, which says that therapists can fail DBT. You're welcome, we can. We'll take the onus on that, and that DBT can fail, okay? Like any evidence-based treatment or any treatment in general, it does not have a 100% success rate. In fact, it's far from it, which happy to talk about more. So DBT can fail even when delivered by the book, right? And therapists can fail when they don't deliver DBT by the book. Now, there was a question about, like, how do I know if this treatment program is delivering DBT? You can test them. You can ask them, are you delivering comprehensive DBT? Which components are you delivering? You can say, are you following the assumptions of DBT? That'll get them to sit up straight. And if they struggle to answer that question, then you know it's probably not the right place in terms of offering DBT. Okay, that's one possibility. We can talk about others. The target hierarchy of DBT, I won't go into the nuance about different stages of DBT other than to say that the first stage is for the most out of control behaviors and the most kind of degree of overt suffering and suicidal behavior. So the hierarchy in DBT is first and foremost, the therapist is working with the client to decrease or eliminate life-threatening behaviors. That's our term, life-threatening behaviors, which refers to suicidal behaviors, homicidal behaviors, imminent threats to life. The mantra is first save life. As Marcia would say, I cannot do therapy with a dead person, right? So I need you to stay alive for the next session, and then the next session after that, and then the next session after that. The second most important thing on our list of targets as a clinician is to decrease what we call therapy interfering behaviors. Therapy interfering behaviors are any behaviors on the part of the client or the therapist that interferes with the delivery of DBT or treatment. So this refers to things like coming late for sessions, leaving sessions early, not canceling in advance, not doing homework, therapists coming late, therapists not being attentive, therapists forgetting important details, right? So these things can happen, and when they do happen, we have to target it. And what I mean by target it is we have to assess, and we have to problem solve. How are we going to get you to not be late next week, for an example? And then after we save life and save treatment, then we go into what we refer to as decreasing quality of life interfering behaviors, which is kind of everything else that interferes with a reasonable quality of life. So again, another question you might think about asking these DBT programs, do you follow the DBT target hierarchy in your treatment, right? At the same time that we're working to decrease all of these target behaviors, we are simultaneously working on increasing behavioral skills. So that's not the fourth thing, that's embedded in how we treat the first three. Okay. Lucky for me, this was already discussed. So how do we build up skills? We talk about these 4 different modes of skills: mindfulness, interpersonal effectiveness, emotion regulation, distress tolerance. I could not agree with Sadia more that everybody could benefit from these skills, right? We all have skills deficits in any one of these areas, and learning how to use these skills in our own lives helps us be more skillful and effective. So we definitely have the mantra, DBT therapists practice the DBT skills. There's no differentiation, oh, you need these skills, but I don't. It's we all need these skills, right? And so many people are doing the work of trying to get skills into as many people's lives as possible. This is a slide that I steal every year from Melanie Harned, who's at the Seattle VA and one of the lead DBT researchers, and every year she does an annual research update at our DBT conference in November, and she updates this slide to say, here are all the trials that have been done on DBT, and Suzanne gave a beautiful overview of how research is done, but you'll see here that roughly the same number of studies have been done on just the skills component as the full model of DBT. And that's important because I think you'll see that the skills are much more able to be accessed and delivered in shorter time frames across multiple populations. So we need studies of the skills alone, as well as studies on the full model of DBT. Suzanne covered this. Thank you. Thank you. Okay. We know that DBT is an evidence-based treatment, and there are a few different organizations that have decreed it as such. The Cochrane collaboration came out with evidence in support of DBT. The APA, Division 12 that Suzanne mentioned, described DBT as having strong research support, which is the highest level on their classification system. The Surgeon General, I didn't write down the year for this, sorry, but the Surgeon General described DBT as helping to reduce suicide behaviors. And as a result of this, somebody, now I can't remember, I think it was Sadia, said that this is probably like the most widely used treatment out there. And we actually don't really have data on that, but I think it certainly is out there in different forms, right? And so I'm going to get to that in a second. But because it has research evidence and because its model is so approachable to so many people, it has been adapted in spades, right? And adaptions include in different types of settings. So now it's not just in outpatient settings as Marcia originally developed it, but you'll see it in inpatient units. You'll see it in partial hospitalization programs. You'll see it in prisons and other correctional facilities. In schools, there is now a whole program on teaching DBT skills as part of social emotional learning curriculum, as long as those last in schools now. And then in universities, you see it as part of college counseling centers and as well as people teaching courses on DBT. And also spread across different populations: borderline personality disorder with comorbid substance use disorder, with comorbid post-traumatic stress disorder, with eating disorders, and with different age ranges. This was a book that came out, I think, in 2021, a co-edited revised edition of a book that describes all the adaptations of DBT across settings and populations. So as somebody who has been in the field a long time and who kind of monitors some of these things, as somebody who's been a dyed-in-the-wool DBT, CBT therapist, I pay a lot of attention to how therapy is represented in the mainstream, and most of the time I am horrified because it's not represented very well most of the time. But it has been fascinating to me to see that even above and beyond CBT, which actually has even more evidence in its favor than DBT, is that DBT is out there in mainstream popular culture ways that I would argue no other treatment is. So for example, you have somebody like Brandon Marshall from the NFL crediting DBT with saving his life. You have Lady Gaga telling Oprah, using skills language, if I'm upset, I'll ask why I am upset. I will write down all the reasons and then I will check the facts, right? That's a DBT skill. That was a little test to see if you recognized it. Did anybody see the Hulk talk about how he uses DBT skills? I am not making this up. You have to go back to the She-Hulk series. In the first episode, there are two things that give me street cred with my sons who are 14 and 11, and this is one of them. I will tell you about the second one. But the Hulk says, dialectical behavior therapy allows us to hold two opposing truths at the same time. And he also talks about how he uses it for emotion regulation. Okay. Selena Gomez has said, DBT has completely changed my life. And then in a different sphere, Peter Attia, who wrote this bestseller book, Outlive, I don't know if any of you have read it or seen it, on the science and art of longevity. It was on the New York Times bestseller list for at least half a year. Includes a chapter on emotional health in which he credits DBT as helping him improve his own emotional health. And he invited me on his podcast a couple years ago, which was a really fun experience. And after that, I got way more emails from tech bros than I ever expected to get in my entire life. But tech bros need help with emotion regulation too. Actually, now that I say it, it makes a lot of sense. Okay, so how do we have this treatment that is out there in the mainstream but is currently not getting funded. And actually, this was a slide that I wrote a year ago. Those of us in the research field have absolutely zero idea what is going to happen to funding in the future. We have no idea what NIH's new priorities are. We know what some of their priorities aren't, but we don't know what their priorities are. We don't know what their budget is. We don't know anything. I am grateful that my salary does not depend on NIH funding. I'm super grateful, but there are people whose salary does, and this is, as you can imagine, a crazy time to be in this field and in this work. But just to say, going back to DBT, is that between these 5 years, only 10 studies had DBT in their main summary when I searched this up on the Grants Reporter website that I hope still exists. And 4 of them were actually one grant, which is a grant I'll tell you about. There's so much we don't know about DBT. We don't know what works for whom, meaning who are the people that we should absolutely refer to DBT versus who are the people that might not need it, would benefit from something else, right? Who are the people, what factors of diagnoses, of life history, of cultural factors would influence? What people might do well with DBT skills versus need the whole package? These are questions that we really don't know the answers to. How much DBT is needed? As I mentioned, it's mostly been studied as a 1-year treatment. For some, that's too much. You don't need a year. For others, that's not enough, right? And we have to figure out how to increase engagement and reduce dropout. We might say DBT has a relatively low dropout, but is 25% something that we want to go for as a dropout of what we think is an evidence-based treatment? We want that number to be lower, right? We want people to be able to stick around in DBT for as long as they can to get the benefits from it. And we don't understand why people drop out. We don't understand how to reduce those factors. We also need work on strategies for increasing access and reducing barriers, as we have talked about. Oh my goodness, that whole time I was just on section 1. Okay, don't worry. I was like, oh, I'll just breeze through this because everybody else has done it. You haven't. Okay. Here are some of the widely known barriers to access. I'll go through each one. Availability. So those of us who do research have been talking about this for years or seeing this written about for years, this idea of a treatment gap, which refers to the difference between the prevalence of a disorder and the proportion of people who are able to receive care, okay? So, for example, it can be estimated that there's over 4 million adults with borderline personality disorder in the US, if you take what the general prevalence is and you extract it to the entire population of the US. And it's also been estimated that over 13 million Americans have serious thoughts about suicide. As of last month, there are 557 certified DBT therapists. I know, that's sad. Okay, here's the thing that I want to tell you. There are other certifying bodies. There are definitely other certifying bodies in other parts of the world, like Europe has its own certifying body. And there are many, many clinicians who do expert DBT that are not certified, okay? I just want to make that clear. Just because someone isn't certified does not mean they're not a good DBT therapist, which I know makes it incredibly confusing as a consumer, and I'll just say that. And if we use this as a metric, just to say, look at this problem, right? And when you look at those 557 certified DBT therapists by the Linehan Board of Certification, that's LBC, these are predominantly English-speaking, urban areas, private practices, and white clinicians. Second barrier, cost. DBT is often touted as being cost effective. Many studies have said DBT is cost effective. And the reason it has been found to be cost effective is because in general, it tends to do better at keeping people out of the hospital or keeping people away from crisis services compared to the control condition. And that saves a lot of money, right? Inpatient units, if you've ever seen the bottom line of that, which probably some of you have, is outrageously expensive. Okay? So if you can prevent an inpatient stay, you're going to be saving money, right? But cost for whom? Who's paying the costs, right? If you have insurance paying for inpatient units, then the fact that DBT might be more cost effective than inpatient units doesn't really matter to you, right? And if you're somebody who's seeking out DBT and you happen to live in the New York metropolitan area where I live, you know that the weekly charge for DBT could be well above $400 a week. This is a minimum, I am afraid to say, which averages out to $20,000 a year, minimum. Who can afford that, right? This is, of course, also excluding the cost of transportation, which is addressed by telehealth a little bit more. Childcare costs, loss of work time. I mean, how many places that offer therapy are only open 9 to 5? It's outrageous. It's outrageous. So we have a lot of barriers in terms of costs there. Time. We talked about what standard comprehensive outpatient DBT is. 1 year, twice weekly appointments, an hour for individual therapy, 2 hour skills training. Who can do that? Of course, lots of people can, and they prioritize that, but there's lots of people with children, people with 2 jobs, who wouldn't be able to do this. I have to be honest and say, I don't think I could fit this into my life for a year, given everything. So we have some barriers there. And then the cultural barriers. We, as I mentioned, are coming a long way reducing stigma, but we still got a long way to go. Stigma prevents people from seeking out care. Stigma prevents people from identifying as having BPD and seeking out BPD specific treatment. Stigma prevents therapists and psychiatrists from telling someone that they seem to meet criteria for BPD, and that gets in the way of those folks getting access to the treatment that would most help them. Most of the research, though this is changing, but a lot of the research has been done with predominantly white female populations, so we know less about other populations. And then there's also issues that have come up with people discounting the skills because they say these examples and the skills are not relevant to me. With my background, my culture, my experiences, I'm going to come back to that. All right, now that I've depressed you thoroughly, I'm going to talk about here are the possible solutions. We have some. Availability and cost. I am a huge believer in training people to do DBT at the earliest level of their training in mental health. I think I have like 10, 12 students here. That's really great. So they will all tell you that I'm right. But teach DBT in graduate and professional programs. And trainees make for excellent therapists. I'm going to tell you this now because I'm afraid I'm going to run out of time later. They still want to learn. I can say this as a middle-aged person, that it is harder to get people as they progress through their career to be willing to learn and try something new. Not always, sometimes, but trainees are eager to learn. And you don't have as much to unlearn to do DBT when you're a trainee than when you've been doing another treatment for 20 years and then start to learn DBT. So we got to start teaching DBT to people in doctoral programs, to people in master's programs. So there is a big movement now to accredit master's programs in psychology, and then for those master's level folks to get licenses. Now, this is already the case in some states, but lots of states don't allow master's folks to get licensed as it is, but that's going to be changing. Now, this is great news in some ways. We're getting more clinicians out there in the world to address the treatment gap issue. It is bad news in other ways because we don't know what they're trained to do. And it is very hard to train somebody in DBT in a 2-year master's program, right? However, we should be on the ground figuring out how do we train the clinicians who are going to be in the inpatient units, who are going to be at community mental health, who are going to be in VA settings, et cetera, in providing DBT. We also need to work hard to increase insurance coverage of DBT services. There are committees of the Linehan Board of Certification who are working on this very issue, which is to work state by state to get contracts with the major insurance companies in those states to reimburse comprehensive DBT. So if you don't live in one of those states, people are working on it, though there's always more that we could be doing, of course. We need to do more research on the efficiency and efficacy of DBT to determine who needs what and how much, and to determine mechanisms. And by that, I mean, like, what are the critical elements of DBT that are responsible for the most change? DBT has 1 million components to it. I don't expect this, but what if we learned that 90% of it was not responsible for the change? Right? And 10% was. If we learned that, you bet we would be focusing on that 10% much more, right? So we don't know that. So right now we throw the kitchen sink at people in hopes that that's what works. I have 5 minutes. Okay. We need to increase diversity in our workforce, in our sample populations, in our research. We need to increase diversity of settings in which DBT is offered. So I don't know if you all are familiar with this stat, but most people who die by suicide have not seen a mental health provider in the year before they die. And who have they seen in the month before they die? Primary care. So we spend a lot of time talking about how to improve DBT services in outpatient mental health centers when actually the people who are going to die by suicide are not even walking in those doors, right? So can we get DBT into primary care? And then relevant examples. I'm gonna have to skip through my entire third thing. Okay, that's okay, I can do it. So I'll cut to the chase here and say that there will be a revised edition of the skills training manual that Marcia wrote coming out, I think, in August. And I was part of a group of people who have worked very long with Marcia, learned directly from her to help with the revisions of that manual. And there are no new skills. There are no major changes to the skills in the revised manual. We changed a lot of the language, not a lot, we changed the language to make it feel more inclusive, to change any kind of implicit bias in the manual so that people felt like it spoke to them a little bit more. We also worked hard to keep in some of Marcia's goofy examples because honestly, I think that's what makes it her treatment, right? So we kept Marcia in the book. But look for that. It should be coming out. Okay, I'm gonna skip. Don't look. Close your eyes. Close your eyes because this will distress you. I'll tell you when to start looking again. Don't worry. Okay, don't worry. Keep going. Don't look. Okay. No, don't look. Wait. Don't look. That's not important. Okay. We did a study. People have mentioned the DBT skills videos that we have developed. Jesse Finkelstein, who's here, was a major contributor to that. Maria Alba helped us with those skills. Am I forgetting somebody? I'm going to feel really guilty about this. If I forgot you, I'm sorry. But what most people don't know, if you've seen those skills, is that was actually developed as part of a research study that we put together super fast. We were given money at the height of COVID, like April 2020. We got a grant, we applied for and got a grant from Rutgers University to develop a light touch intervention for college students experiencing the distress of COVID during that year of not being in person on campus. And we put these, I still can't believe it, honestly, because I had a first grader and a third grader at home, and we were all like getting used to Zoom for the first time, that we made these beautiful videos. And we did the study, and the study found that they were effective, and I skipped over the details, so just trust me on that. And then we put them up on YouTube to make them freely available. And I mentioned the second thing that gives me street cred with my children, besides the Hulk, is that I check these data every so often, and the videos now have 2.8 million views. It does not compete with Mr. Beast, who I'm told has way more views than me. And we translated them. We had people approach us and say, can I translate these into Mandarin and put them on a different platform, because YouTube is not accessible in China, so that people in China can access them? The first people that came to me were the French Canadians, and translated it into French. We have Spanish, we have Brazilian Portuguese, we have Norwegian. And now I'm told actually that YouTube can just automatically translate. So if you have a language that's not there, you can look for that. This has been a direction that I did not expect my career to go, which is how to make these skills freely available in ways that people can use in however they see fit. So what I have heard about these videos so much is clinicians go to them, clinicians learn the skills from them before they then teach. Clinicians show the video in skills groups and then have discussions about that. But then we're also finding that clients are finding it, or just people who want skills training, whether they meet criteria for borderline personality disorder or not, are finding them online and using them. And that really just brings me so much joy and hope that we could use technology in this way to get skills out to as many people as possible. So I'm going to end just by sharing with you some of these resources. There's the YouTube page. We also developed some handouts and worksheets for DBT that we then made freely available and are on the website. And we have a skills book. Jesse and I have a skills book coming out in November. Sadia, you didn't know this, but you actually just gave the best pitch for my skills book. So I swear she didn't know this. Thank you. And when I submitted these slides, we did not have a title. Now we have a title, but I think I'm a little too scared to say it. So, okay. Wordle, did you say? I did not cheat. Is that what you're implying? Okay. Real skills for real life. Okay. Then there's a subtitle, DBT Guide to Navigating Stress, Emotions, and Relationships. We'll figure that out. It's coming. Okay. I'm sorry I didn't get to a lot of my slides, but have me back and I'll do a part 2. Thank you.
Thank you so much, Dr. Rizvi, for your very, very amazing talk. I'm actually one of the clinicians who have used your skills in DBT Skills Group. So thank you so much for all the work that you've done so far, and I'm excited to see what you have going forward as well. And so because we're strapped on time a little bit, we do have one question that came in of the many. And again, if you have some questions, we will have a panel discussion at the end of the day. So if you don't hear your question right now, you're gonna probably hear it at the end. But so one question we got for you is, how do we work with individuals whose cognitive functions are affected by their mental health diagnosis?
Cognitive functions. So by that, I'm going to interpret this question in a particular way, and if I'm wrong with my interpretation, come find me and let me know. But cognitive difficulties, meaning inability to process information, and difficulties with learning the skills based on how the skills are taught and their cognitive level. There's a woman named Julie Brown who wrote a book called The DBT Skills System that is based on her work with individuals with intellectual disabilities. And she has developed her own handouts and resources for teaching DBT to different levels of cognitive functioning. And if this is answering that particular question, I would say go find the DBT Skills System books for loads of examples to how to teach the skills, perhaps in ways that are more accessible.